Okay. So hi everyone. Christoph and I, Ren, we're in Psych Congress at San Diego today.
Yes, welcome from a city that actually had rain yesterday. I thought there's never rain in San Diego, but there was. And we have lots of people here that are trying to be educated on psychiatric matters. And there are obviously lots of symposia and talks. But today we want to summarize some of the posters that have some new data that might be of interest to you.
Well, first, I heard there's a study confirming the results from randomized trials in the real world. How did that work and what's the result?
So first of all, why is it important? You know that we do a lot of evidence-based care studies looking at randomized controlled trials, but these are patients who actually say, yes, I have the illness, please study me. I'm willing to sign a consent form, understand what it means. That's already a pre-selection. Actually, Jari Tihonen and Heidi Taipale from Finland examined in their database how many patients in the national database in Finland would qualify for randomized controlled trials in schizophrenia. So meaning they have one diagnosis, that's the main diagnosis. They don't have too many problematic somatic comorbidities. They don't have too many co-medications. They don't have suicidality, substance abuse. And actually turns out 80% of patients are not eligible for the trials. Only 20% are. And when you look at the outcome in the real world, the 80% not eligible have a poorer outcome because they're basically not as clean. So when we then have data that come from randomized trials, the question is always, for clinicians particularly, are these my patients? Can I trust and believe the data? So one of the posters actually where I'm the first author on, and I'm partnering together with J&J, and this was the question about paliperidone 6 monthly. Obviously, long-acting injectables are important. We have different injection intervals, 2 weekly, 4 weekly, 6 weekly, bi-monthly, 3 monthly, now 6 monthly. And in order to get to paliperidone 6 monthly, you either have had to have been at least on 4 months on the 1 monthly, with the last 2 doses being the same dose, or the last 2 injections being the same dose, or at least 1 3-monthly injection. And then you can go to the 6 monthly. And in that study, there was a comparison of people 6 months versus 3 months, and basically the relapse rate was only 7%. That's a very low relapse rate for a year, but it may be because people are pre-selected, agreeing to be in the study. So in this study, we then looked at real-world data from Market Scan in the United States and tried to look at the same inclusion criteria. It was about 120 patients or so in each arm, and confirmed that even in those patients who are in the real world, the relapse was 9%. So 7 versus 9% on 6 monthly shows us we can actually believe those data, obviously in patients that have these profiles, which is an important addition to the armamentarium of evidence-based medicine. I will talk later at the end what MedLink Global is doing right now, getting more than just 120 patients to learn from, but we need to supplement the randomized controlled data with real-world data in order to really make this palatable and also tangible for clinicians.
Sounds very interesting. I thought usually it's randomized already kind of representing, but it's not actually. So our second poster that is talking about treating agitation in the home environment, how does that work?
Yeah, so we have obviously agitation is the fever of psychiatry. It brings people into more confined treatment settings. And the problem is that often patients that have schizophrenia or bipolar disorder, when they get into stressful situations, maybe they go to the mall, they hear more voices, they can get very agitated. That can then trigger calling the police, maybe going to the emergency room, which is disruptive for everyone, including the patient. So wouldn't it be great to have maybe family members or caretakers being able to give something to the patient who's getting revved up? And we often use benzodiazepines for that in a controlled setting, but it's hard to give like a 30-tablet prescription for the outpatient care because that could be abused, it could be sold. So it's really not something that we would not necessarily do, and it also doesn't work as fast. So there's a new treatment that's actually been approved for treatment by a clinician. So it has to be a healthcare professional, and that's called dexmedetomidine. And it's an alpha-2 agonist, has been around for a long time as a IV anesthetic to calm people down, because when you stimulate alpha-2 receptors, that are autoreceptors on the noradrenergic system, you're decreasing noradrenaline. And noradrenaline is obviously the fight or flight kind of neurotransmitter. And this has now been reformulated as a sublingual formulation. It's approved for bipolar disorder and also schizophrenia. But since it's an alpha-2 agonist, which decreases noradrenaline, it can also decrease blood pressure. That's how alpha-2 agonists were developed as oral treatments. And with that, since there can be a decrease in blood pressure, it has to be supervised by a healthcare professional. You can't just give it to a caretaker who then maybe gives that and has like a 20-minute later a good reduction in the agitation. So in order to then bring this into the home setting, the company had done an open label study, which is postered right now, against lorazepam, which is an benzodiazepine, and actually at a lower dose didn't cause much in terms of the hypotension, and held its own against lorazepam. And we're presenting this now because there has been a press release very lately that a larger randomized study, also not a randomized study, but a study of home use, also showed safety, that it can be administered safely at home in order to help patients treat the agitation. So it's another option and may actually avert people having to go to the emergency room.
Oh, that sounds really nice. In the first time see the title, I thought it was some educational training for the family member, but now it seems like we have a very effective way to taking care of the agitation piece at home. So the third poster we're going to talking about is enhancing adherence to and outcome of olanzapine, right? Can you tell more about that?
Yeah, it's actually two posters and it's two approaches. Let's talk first about oral olanzapine, where samidorphan, a mu-opioid receptor antagonist, is added. We know that olanzapine is a very effective antipsychotic. Actually, in long-term studies, whether it's CATIE or other studies, it has been shown that patients, despite weight gain, which is its Achilles heel, have complied with or adhered to olanzapine more than with other agents. So it seems to convey something that keeps people on treatment. And obviously, when people are on treatment, they have better outcomes. Now, adding samidorphan to olanzapine can reduce the weight gain. There is a lag time of about 4 weeks when the weight is similar, the gain, whether you have olanzapine without samidorphan or you add samidorphan. But after that, it often, at least in the trials that were reported and that I was also able to be part of, there is a flattening of the line. And while in bigger samples or the complete sample, there didn't seem to be a metabolic advantage, but in people who didn't have metabolic syndrome or didn't have hypertension, even those, there could be a reduction in the incidence of that. Now, the question then was, this is a randomized controlled trials, would that again translate into the real world by looking at patients who are on olanzapine samidorphan and comparing that to olanzapine treated patients, which already is a treatment where people adhere to it and it has pretty good outcome. And the data that were presented show that actually even above and beyond the effect of olanzapine with samidorphan seems to improve adherence. Patients stay on the treatment longer, they discontinue less. With that, they have less hospitalization rates and less relapse rates. So basically, better outcome. And by reducing the weight gain. So it seems that weight gain is a predictor of stopping medication, even with olanzapine. And that adds another option to the treatment with olanzapine when olanzapine is needed in patients who have actually more severe illness. So that's the one poster. But another poster is trying to look at olanzapine not as an oral treatment, but as a long-acting injectable. And olanzapine long-acting injectable has been around for quite a while as a deep intramuscular injection. But olanzapine is very water and blood soluble. And when you do a deep intramuscular injection, you can lacerate a blood vessel. And then all of the medication that's either designed to be released over 2 or 4 weeks gets into the bloodstream and can cause so much sedation that people keel over or even stop breathing. So that's why it's called PDSS, the post-injection delirium sedation syndrome, PDSS, happens only in 1 of 1,200 injections, but it can be potentially fatal. So that's why you need to observe patients 3 hours after the injection. And because of that, almost no one is using olanzapine as a long-acting injectable. We have olanzapine for the second-generation agents for risperidone and paliperidone as one family. Almost 6 different formulations and agents exist. And we have aripiprazole as a family with 2 different representatives. But olanzapine is missing in our armamentarium. And there are about 20% of patients in the US, and in Europe is almost 30%, that currently are treated with oral olanzapine. But we can't, and these are often more severely ill patients, we can't offer them an LAI. So here, olanzapine subcutaneous LAI has 2 advantages. One, it doesn't go deep intramuscular. So the subcutaneous tissue is much less vascularized, and therefore it's much less likely that the medication spills over into the bloodstream. But it's also a polymer formulation. So even when you directly inject the subcutaneous olanzapine that's given once a month into the bloodstream, only 15% is released. The rest is actually flocks out, basically. And with that, you don't have the risk of post-injection deliriums, and you don't need the observation, the REMS program. So the FDA then mandated, okay, show me first that the subcutaneous LAI olanzapine, which actually reaches blood levels within 24 hours. You don't need oral co-treatment, you don't need a booster injection or loading dose. But show me first in 8 weeks that it actually works as an antipsychotic, that this formulation doesn't detract from the efficacy. And that's the Solaris study, phase 1, check. It worked at an equivalent of 10, 15, and 20 milligrams, both for the primary outcome, which is total PANSS reduction against placebo, but also all secondary outcomes. So that was great. But the big question now was, if you can treat people with long-acting injectable olanzapine, subcutaneous, does it not cause any PDSS as it would be predicted by the subcutaneous injection and the polymer formulation? And actually, with more than 3,400 injections in the Solaris program, that was a 48-week extension, there was no PDSS. And actually, when you put the whole program together, it's more than 3,900 injections. So with that, we know now that subcutaneous LAI olanzapine LAI could also be another option to improve the adherence to olanzapine in some patients who are willing and able to accept the LAI and then improve outcomes overall.
Oh, wow. That must be a relief for the very sick patients who cannot stick like daily oral olanzapine.
Yes, and there are different reasons why people don't adhere. It could be lack of illness insight, so you may have to get them on this regular injection. It could be fear of side effects. It could be inefficacy with other long-acting injectables or oral treatments. So we will have another option at least available that is safe, and that's, I think, important.
Yeah. I also heard some news from the muscarinic. Can you help me?
The muscarinic activator medication front. Yes, so as many of you who are listening know, we had a revolution in the treatment of psychosis in the fact that after 7 decades of just postsynaptic dopamine modulation, which is already very helpful for many patients, full antagonism, partial agonism, but we didn't dial in another receptor system for efficacy, despite the fact that second-generation antipsychotics also block 5-HT2A receptors, but that we now have a new class of medications that modifies or modulates a different neurotransmitter system. And that's the cholinergic system, and actually not the nicotinergic, but the muscarinic part of the cholinergic system. And why is that important? Because we've actually given short shrift to the muscarinic system and the cholinergic system. We've only relegated this to, okay, let's use a peripheral anticholinergic to treat Parkinsonism and extrapyramidal side effects. But we now start to realize that the cholinergic system is actually an orchestrator of multiple different neurotransmitters, modulating GABA, the brake in the system, which then modulates glutamate, the gas pedal, and glutamate input into the midbrain gives too much dopamine output. So stimulating M1 receptors can help stimulate GABA, the brake, reducing glutamate, reducing presynaptic dopamine. And then the M4 receptor that stimulates an autoreceptor, decreases the hindbrain to midbrain cholinergic input, which then also reduces dopamine output in the striatum. And there's also a part of an interneuron in the striatum that when you stimulate M4 receptors, again, reduces dopamine output. So that's wonderful. And we have an additional treatment. But whenever you have something new, it's hard to know how to use it. Mm-hmm. And so the poster that we're talking about now is actually a switch poster. The problem with randomized controlled trials is you usually wash out patients, they're on nothing, and then you basically randomize them to placebo or drug. So you don't know how could I bring them from current antipsychotic to the new treatment for psychosis. Mm-hmm. And so this was a observational study seeing what do clinicians do when xanomeline trospium, which is an M1, M4 muscarinic agonist, is entering the scene in a patient with schizophrenia. And it turns out that most of the patients, actually almost half of them, got a cross titration. So as you're bringing up muscarinic agonism, xanomeline trospium, which needs to be titrated at least 2 days of 50 milligrams, xanomeline 20 trospium for 2 days minimum, could be longer. And then you have in the acute trials 5 days of 100 milligrams xanomeline, 20 milligrams trospium, twice a day. And then as of day 8, it started to be 125 milligrams xanomeline and 30 milligrams trospium. It turned out that most clinicians actually are not in the clinical outpatient world adhere to this fast titration. It's basically more around 2 weeks. Most people take 2 weeks, and then the second most time frame of the switching is actually 2 to 4 weeks. And it's mostly that as you're going down on the current antipsychotic, people are moving up. They're also, that's about half, a very 7% only went cold turkey, stopped the first agent and go to the next. Wasn't disclosed, but most likely this is with partial agonists that have a 3-day half-life, brexpiprazole, aripiprazole, or even a 7-day half-life, cariprazine. So there you can stop more abruptly. But there are also others that actually bring up xanomeline trospium first, keep the antipsychotic where it is, and then after a week or two, bring it down. And it seemed that that worked pretty well. There was more of an nausea signal than we had seen in the trials. Nausea was in the trials about 20%. This was 69%, but it seems still that patients were able to deal with it. It attenuated over time, and also ondansetron was used not prophylactically, but when the nausea happened, it was moved in to keep people on the treatment. So that gives us some real-world data, how to switch, most likely giving it some more time than was done with the titration, than was done in the clinical trials. And then there was another poster, which is very interesting, that has to do with xanomeline trospium in the ARISE program. So there are 3 emergent studies, which are 5-week acute studies for the inpatients. But the ARISE program was the question, well, we have postsynaptic dopamine blockers on board, and they only do partially the job that they should do. So there's still residual positive symptomatology. Could you add xanomeline trospium, which has presynaptic dopamine reduction effects, and thereby synergistically treat these difficult to treat patients with schizophrenia for positive symptoms? They're enriched for positive symptoms. Okay. This hasn't been published yet, but it's there was a press release that overall, unfortunately, xanomeline trospium added to antipsychotics did not meet the primary endpoint of decreasing total PANSS in everyone. But there was a subgroup of patients, about 2/3, that were not on risperidone, that were on other antipsychotics. And there, the addition did help with the total PANSS, but not with risperidone. And we still need to understand that. Is that because risperidone doesn't only block post, but also presynaptic dopamine receptors? Actually, it is one of the agents that has equal blockade of both. And when you block presynaptic dopamine receptors, maybe you increase some of the presynaptic dopamine tone, and the dose that is sufficient against placebo when you don't have another antipsychotic on board is not enough. Should you have been on a higher dose? Also, this was just a 6-week study, the ARISE study. In the acute studies, it was a 5-week study, and titration ended at week 1. So you had 4 weeks full dose. In the 6-week study, they had 3 weeks up titration. So there was only a 3-week full dose. So maybe this all contributed. But why I'm telling you this is there's now a poster of reanalyzing the data and looking at not total PANS, but positive symptoms. And remember, these patients are enriched for and identified for having residual positive symptoms. And guess what? Even the risperidone-treated patients, everyone, when you look at positive symptoms, xanomeline and trospium added to ongoing antipsychotics, separated from placebo. So it treats psychosis and positive symptoms. And that raises another question. With a drug that doesn't have postsynaptic dopamine blockade, doesn't have much sedation, maybe the PANS total is not the best outcome, because here you have 16 general psychopathology items: restlessness, sleeplessness, anxiety. And that's not what this drug does well, or what muscarinic activators will do. Maybe we should shift to the treatment of positive symptoms. And that's interesting because valbenazine, which is a VMAT2 inhibitor, also reducing presynaptic packaging of dopamine, among other monoaminergic amines, also didn't separate, adding it to antipsychotics for total PANS, but it separated for positive symptoms. So that tells us modulating presynaptic dopamine tone in addition to postsynaptic dopamine blockade in patients enriched for positive symptoms may need a positive symptom outcome, because we want to treat psychosis, don't we? As we do for enrichment for negative symptoms, where we also have the negative symptom factor score or the Marder score or the BINS or whatever as our primary outcome. So I think the field needs to rethink with different mechanisms of action, different outcomes, and also when you enrich for certain symptoms, that this becomes your outcome. So quite exciting. So we're back in the game of augmentation, but not for total symptoms, which is basically non-specific, but for positive symptoms, psychosis.
Wow. That's a lot of, what should I say? It's not improvement, but he said it's like a new development after a while.
So whenever you have a new class of medication, we need to understand this class of medication, where it works, for which symptoms, for which patients, and in which combinations. And I think we still will learn a lot about the muscarinic modulators. And there are now currently 14 different ones in the running at different stages, lots of them in phase 1. But we will learn much more how they differentiate and for which indications they can be given, because they're not just used now and tested for schizophrenia, but also psychosis in Alzheimer's disease, agitation in Alzheimer's disease, and also bipolar mania. So those are the current programs. But you can think of other indications for agents that reduce presynaptic dopamine, where we do think that is maybe part of the pathophysiology.
Well, thank you so much for, I learned a lot about neurotransmitter and medication. And our last topic is quite exciting. It's about machine learning. It's the era of machine learning and AI in the whole world, including the field of psychiatry. I heard organization is building a predicting treatment response, and I want to know like how effective it is and how it's actually, capturing what kind of data to representing patients and to representing the treatment response.
Yeah, so machine learning and artificial intelligence most likely has the most utility when you have lots of data and also unstructured data, and it's hard to make heads and tails of it. This application in the poster that we're reporting on now actually used randomized controlled data. So you have very structured data points of the total PANS, of quality of life scale, of functioning scale. And instead of doing, quote unquote, just a regression analysis, the question here was with the aripiprazole long-acting injectable, which patients benefit the most or benefit not as much from the long-acting injectable aripiprazole for relapse prevention. And it turned out, by machine learning, that it was more severe symptoms were harder to then stabilize. And we've shown that also with breakthrough psychosis on long-acting injectables, that when people were not fully stabilized, they're more likely to relapse again. And patients who were less functionally in remission and had poorer quality of life. So again, worse outcome at the beginning predicts worse outcome at the end. but it may look a little tautological. But on the other hand, it helps clinicians to say, okay, with those patients, I may need to put an extra eye on them.
Yeah.
And we found in other studies that actually substance use and tardive dyskinesia were also two predictors of even breakthrough on long-acting injectables. But it just gives us a glimpse into we may want to utilize new methodologies in order to enhance our predictive power. But now it's your turn to tell us about what MedLink Global is doing with machine learning in real-world data, where I think the application is much more relevant.
Sure. So MedLink Global has two big parts, right? Our first innovation is about a diagnostic engine that include the very standard patient intake, capturing all the facts of the person, plus the minds that we designed in-house and capturing all the psychopathology profile of a person. Like both these contribute to a more comprehensive and more accurate diagnosis of like capturing the whole.
So measurement-based care is made possible without spending the time because basically our AI engine does that assessment.
Exactly. There's all the measurement by talking to the patient, asking the right question, and then gaining and collecting and cleaning and organizing all the meaningful insights. And the second innovation, and we don't stop at diagnosis, of course. The second one is even more exciting, I would say, is really building a treatment response, like predictive treatment response model, and then followed by a better treatment planning suggestion. And this is exciting because we got a lot of interesting data and unique from our strategic partnership with Mayo Clinic, which is, of course, our honor to work with them together and to have the access to all their 32 million patients data that is de-identified. We can learn so much from the history, what worked, what didn't work, what worked for who, then to have this treatment response prediction. And then on top of that, we can come up with all the treatment planning based on what didn't work before to overall improve the outcome of our treatment.
So basically, you're telling us learning from other patients for your patients. So if there are patterns that we've identified for different strata, and that's basically maybe not personalized, but stratified psychiatry, predictive psychiatry. And then when you put in the data or the agent puts in the data of your patient, having asked all these questions, then you get a profile and it's compared to the profiles of other patients at that treatment journey. And then different treatment options are given to the clinician with a ranking of, in general, this might work a little better than that. The clinician still makes the decision. Absolutely. We still need the clinician. Nobody will be replaced here.
Right.
We're just trying to enhance care by making measurement possible and also predictive values that we as human beings couldn't draw from hundreds of thousands of notes from certain patients that are on the same medication or that are in the same diagnostic group.
Right. And this treatment suggestion model will make sure every new patient coming in, they contribute to the next patient's quality of care. So we learn from every new patient.
Now, this is the beginning, correct? The program starts in October. We just got this bid and you actually won it, so that we are one of 7 companies working with the Mayo Clinic. They have certain cohorts where they allow the data usage, and we hope that we can then build our treatment co-pilot, which is not making the decisions for you. It's a co-pilot. You're still the deciding entity, but in a more informed way with knowledge that we could otherwise not provide.
Not able to processing that moment of all the data in your head.
And that comes in addition to all of the book knowledge and the research studies that we also have fed into the co-pilot model. So it's basically both.
Eventually, our model should be also interactive. For example, we suggest you a list of treatment suggestions, and you may have questions, right? You may think, why you suggest me this? And you can ask. There will be an interactive model that you can learn from where we draw that conclusion and suggestion. And of course, safety first. This model will be first clinically validated by Mayo Clinic before we launch it next year.
And then basically we also see the feedback, how the patient is doing that you are treating. There are like touch points where the patient can again be interviewed by the AI agent so that we track the outcome, whether it's minds or something else. So it will be a self-learning, a health system tool that will hopefully enhance our outcome prediction and therefore also the treatment of patients. And hopefully they will be happier and we can also save time.
Yeah, they can land to the effective treatment sooner than the status quo. Sure. One last exciting update. We will be live soon in Athena House. For those who use Athena House EHR called Athena 1 today, MedLink will be available, I think, by end of this month. By just one click away, then all your patients can have access to our diagnostic engine, Minds, and our patient intake.
And in the future, then once we've built a co-pilot, that will also be available.
Sure, yes.
Well, we hope this was helpful to you coming from San Diego Psych Congress. And if you can't be here, that we gave you some of the knowledge that at least we felt was relevant to share with you, and also some updates from MedLink Global.